Hello everyone and welcome back. My name is John and I'm one of the final year critical care fellows at Dalhousie University. Thank you so much for tuning in today for part 3 of my 7-part learning module on oxygen delivery and oxygen consumption in the evaluation of oxygen balance in hypoxemic respiratory failure requiring VV-ECMO. Last time we reviewed the definition of hypoxemia, discussed the 5 broad categories of hypoxemia, and also learned about the AA gradient, as well as how to calculate it and apply it to narrow our differential diagnosis for hypoxemia. Today we'll be discussing the general management of hypoxemia both inside and outside of the ICU. In this section, we'll discuss the approach to escalating supplemental oxygen in the management of hypoxemia, as well as the role of positive pressure ventilation in hypoxemic respiratory failure. Building off of this, we'll also discuss the concepts behind lung protective ventilation, and finally discuss briefly the role of veno-venous ECMO in the management of severe refractory hypoxemic respiratory failure. As hypoxemia represents such a common admission diagnosis to ICU and common problem affecting patients during ICU admission, it's likely that you're already familiar with the approach to managing hypoxemia with escalating amounts of supplemental oxygen. The right side of this slide shows the general ladder of escalation beginning at simple nasal cannulas and progressing upward through oxygen face mask and onto high-flow nasal cannulas, all the way to non-invasive ventilation and finally endotracheal intubation to facilitate invasive positive pressure ventilation. As we have alluded to, the initial approach to management is largely aimed at increasing the amount of VO2 of the air inhaled by the patient. The aim of this is to increase the partial pressure of oxygen delivered to the alveolar capillary membrane in hopes of overcoming challenges with diffusion. Increasing FiO2 can be accomplished by increasing the amount of oxygen delivered by a certain modality, as seen in the table presented here, or by escalating the modality in which the oxygen is being delivered. Nasal prongs, as depicted here in the left image, are a common starting modality for supplemental oxygen delivery. The delivered FiO2 can be increased by increasing the flow rate of oxygen through the nasal prongs. If nasal prongs are insufficient or the patient may benefit from oxygen therapy being delivered through the mouth, nasal prongs can be changed out for an oxygen face mask as depicted in the image on the right. In addition to these classic methods of supplemental oxygen delivery, there are newer options such as high-flow nasal cannulas, or brand names Airvo or Optiflow, which deliver high-flow, heated, humidified oxygen through nasal prongs at rates of up to 60 liters a minute and up to about 95% FiO2. High-flow nasal cannulas have certain advantages over standard supplemental oxygen delivery modalities, including delivery of high rates of flow that can decrease work of breathing, delivering humidified air, which can help prevent drying of mucous membranes, and possibly the addition of some level of positive end expiratory pressure to the upper airways. Important to understand is that the strategy of increasing FiO2 will not be effective for all causes of hypoxemia. The reason for this is that this approach relies on functioning alveolar units which both receive oxygen and are capable of facilitating its transfer across a functioning alveolar capillary membrane into the blood. As in the case illustrated here, if the alveoli are not open and therefore not receiving oxygen, then increasing the FiO2 will have little to no effect on the resulting hypoxemia. As such, if simple escalation in supplemental oxygen therapy is ineffective, more aggressive strategies may need to be explored. If the approach to hypoxemia management needs to incorporate methods of recruiting or reopening collapsed alveoli, then the strategy will likely require a modality capable of delivering positive pressure ventilation. Positive pressure ventilation can be delivered through the use of tight-fitting masks like the non-invasive or brand name BiPAP mask seen here on the left, or through endotracheal intubation in combination with a mechanical ventilator as depicted on the right. As illustrated here, the positive pressure delivered by, for example, a mechanical ventilator forces the collapsed alveoli open by adding pressure inside of them, creating a distending force from within. Once open, the alveoli can again participate in gas exchange, possibly improving hypoxemia. Positive end expiratory pressure, or PEEP, is another force that can be applied to patients receiving positive pressure ventilation. PEEP ensures that some amount of pressure remains in the alveoli throughout the respiratory cycle, thus continuously stenting recruited alveoli open, avoiding further collapse and possibly re-recruiting more collapsed alveoli over time that can then participate in gas exchange. Although the mechanical ventilator is capable of generating supraphysiologic pressures to support patients experiencing respiratory failure, in some rare but severe situations, the pressures may not be adequate, or at some point, the very pressures required to achieve adequate oxygenation may be damaging to the lung parenchyma. Because of this knowledge, we strive to operate the ventilator within certain parameters which we believe to be safe for patients' lungs. These parameters together form the foundation of lung protective ventilation and are listed in the table before you here for your reference. In cases of severe and refractory hypoxemia, an alternative strategy is necessary to provide oxygen to patients in order to sustain life while allowing time for their lungs to rest and hopefully recover. Such a modality exists in the form of veno-venous extracorporeal membrane oxygenation, or VV-ECMO for short. In VV-ECMO, a patient's deoxygenated blood is removed from their venous circulation and circulated outside of their body, where it's oxygenated and scrubbed of carbon dioxide before being returned to the patient, where it enters the circulation again. Oxygen is supplied to the blood by the membrane lung or membrane oxygenator as part of the VV-ECMO circuit. This oxygen provides a continuous supply of oxygen to support aerobic metabolism while the lungs rest and heal. Once a patient's lung pathology has progressed to the point of requiring VV-ECMO, it's important to understand that the ability to improve oxygenation further is limited, and troubleshooting is limited to adjusting variables of the VV-ECMO circuit or modifying certain patient factors as discussed below. And that brings us to the end of part 3. In this section, we've discussed the management of hypoxemia, including the standard supplemental oxygen escalation from nasal prongs to oxygen face masks to high-flow nasal cannulas, the non-invasive ventilation to endotracheal intubation. We briefly discussed the benefits of positive pressure ventilation and recruiting alveolar lung units so that they may again participate in gas exchange, thus improving VQ mismatch. We also introduced the concept of VV-ECMO for cases of refractory hypoxemia or hypoxemic respiratory failure requiring dangerous ventilator settings. Thank you so much for your attention today. I hope you can join me for part 4 of this learning module next, where we will review the VV-ECMO circuit.